tend to use as one of its primary propulsive muscle during running. So of course that thing is going to have high tone all the time. One of the things you always need to pay attention to is, and we may not all be able to fully figure this out, but ask yourself when you're looking at someone that actually has a dorsiflexion restriction, is it related to joint? Is it related to the muscle itself? Is the muscle actually limited in its length? Or is there some guarding or some like tone that's preventing things? And that should hopefully allow you to try things to go, hey, maybe I also need to do some soft tissue or foam line or what have you, and then go into a dynamic or static stretch. Because combinations of treatments tend to be a little bit better for actually getting longer range of motion gains, or more like long-term gains. The other thing I would encourage you that's been really instrumental for my practice that is probably going to be most people go, is that as soon as you start working into that range of motion, use it. And there's a couple different ways you can do that. Obviously, if you get someone into a good calf stretch position, they're holding this thing, it might be good, again, if you're trying to maintain this, to actually go, okay, now that we're going to use this range of motion, let's start with maybe body weight and then load up into those greater degrees of dorsiflexion. So if you're going to use the agonist muscle, awesome. The other option you can do, I'm trying to figure out where I can do this without breaking anything, having them actively dorsiflex here. I'm not sure if you can see that, but again, now antagonist working through that range. If you want to have a lot of fun, have them do this in single leg, because the active push in the calcaneus down to the ground, at least my theory, is that you just get a lot better articulation of that talar crural joint. But whatever you do with mobility stuff, make sure you make them use it right afterwards. If not, we know that like foam rolling, soft tissue work, a lot of that stuff, if it's not used afterwards, those range of motion gains may not be as long as we want. And we know the same thing with stretching. It can be a potent tool if used the right way, but more isn't better frequently. And doing, hey, get into that range, hang out there, and then use it as much as possible, whatever, in a variety of different ways is really helpful, is key. So definitely trying to get mobility stuff, I'd encourage a multimodal approach, because not only evidence, but some good clinical practice has been that can be really helpful to make that not just a, oh, I felt better for that second, now I re-stiffen, especially with the group that tends to use these muscles over and over and over and over and over and over and over again. Hamstrings are also very similar, just also be very careful with hamstrings and calf, because some of that stiffness can actually make people faster and more elastic. So if you're going to take that away, sometimes that can significantly slow that down. I say that someone who has done that, unfortunately, to many elite athletes, and they're like, oh, well, like, it feels better, but now I'm running way slower. I'm like, oh, we took away that like elastic thing that probably helped you be better. Maybe we could have done that a little differently. So figure out what's most appropriate for them, if that's actually them guarding or if that's just something that's unique to them. Because runners don't typically have great hamstring range of motion. It makes them efficient. All right, are we ready to jump?
So I had a question in regards to, so you've shown several like calf raise and Achilles based stuff.
Yeah.
We emphasize the importance of the lower leg when it comes to running. So taking someone from ground zero to what you're about to do, essentially through your strength progression and right up to your plyometric, what does your progression look like?
That's a great question. It will depend on what exactly we're going for in terms of, is this rehab or is this just for like, hey, you got this injury that you're able to run, but we can just load this and get you better. But primarily what this is going to look like is progressing from double leg, unless of course we're working on bone, we're going to move towards single leg. So double leg calf raise, moving into single leg stuff, getting in some good weight, and knowing that for like a couple weeks, at least, preferably 3 to 4 weeks, enough time to actually make some physiologic change in the muscle itself, not have to be neurologic. After that time, hopefully we've gotten them into single leg position, they're comfortable. Then we're going to progress them, and whatever power thing we're going to do is going to be regressed to double leg only. But at least 3 to 4 weeks of doing true strength work before I'm going to consider really getting into power stuff. If we are truly rehabbing an injury that they cannot run with them. Mike, would you add anything? What does your progression look like?
Yeah, so if we're thinking through a specific case scenario, I mean, let's say someone's starting at baseline 0, so ankle sprain with an ORIF of the fibula, non-weight bearing, but they've been non-weight bearing bone, and they've also been non-weight bearing for some time. So how do you sequentially take them from ground zero and work your way up. I would start them in seated calf raise. I'd start them with isometrics because typically there's deconditioning of the connective tissue, and you need to load the connective tissue, that is the intramuscular connective tissue, as well as the tendons first, to build infrastructure before you work on said red tissue or muscle tissue. It's usually a little less irritating because they still have some swelling and some sensitivity around their area. And so I will try and exhaust them as much as I possibly can with seated isometrics, and then working into isotonics. What is my criteria for that? A tolerance of doing at least 1 to 2 weeks of the isometric work. And they're usually doing this with either a TheraBand around their bottom of their foot and over their knee, and or with a dumbbell on top of their knee. We then incrementally work towards straight knee progression. This is done usually with partial body weight. So either if they have access to a leg press, great. If they have access to a commercial gym that has a calf raise machine where they can use partial body weight, excellent. If they can't, then we're starting with like a bent over, essentially a donkey calf raise that we described yesterday. And so that's all before that's even less than double limb. Once they're on double limb, then you can go through your more standard progression that you were talking about. I think it's being able to slice your progressions and have granularity and criteria is necessary for really structured rehab, so you can meet the person where they're at.